Okay, we might make a start. Just the first minute or so is only me talking anyway, so they won't miss anything super important. Hello everyone. My name's Megan. I'm the admin assistant for the APS Psychology of Eating, Weight and Body Image Interest Group. On behalf of the committee, I'd like to welcome you all to the webinar. I'd also like to acknowledge the traditional custodians of the land on which we meet today and pay my respects to their elders past, present and future. I'd also like to pass on our sincere apologies for the technical issues we have experienced today and for the last minute change to the Zoom link. Thank you all so much for being so accommodating with that and for making it over to this link. And thank you very much for Sharon for saving the day there. So today, Danica Adolfson and Kate Goff will be presenting the workshop, A Multidisciplinary Approach to CBT and Eating Disorders. We anticipate that you will gain an improved understanding of a multidisciplinary approach to CBT for eating disorders and how this can be applied in private practice, as well as an enhanced understanding of how a dietitian, psychologist and GP can work together to maximise the efficacy of CBTE under the new Medicare Eating Disorder Treatment Plan. Throughout the presentation, I encourage you to leave any questions you have in the chat. I'll be recording them, so if they get kind of lost in the chat, don't worry. I'll be saving them, and we'll have about 20 minutes of question time before the end of today's session. We also ask that you please make sure your microphone is muted. You can find the mute button on the bottom left-hand side of your screen. This session will also be recorded for the Pubic Committee. While the recording will not be distributed, you may wish to be mindful of this if you are using your video. We'd love to see your faces during the presentation, but if you would prefer not to be recorded, please, of course, feel free to switch off your video. That's completely fine. So thank you very, very much again for being so accommodating today, and apologies for the issues we were having with the technology. And thank you so much for joining us. I'll now hand over to Danica and Kate.
Hi, everyone. So my name's Danica. I am a clinical psychologist and I work at Centre for Integrative Health, or CFIH for short. And this is my colleague Kate, who is an accredited practicing dietitian who also works at CFIH. And we work together in a team, and we'll tell you a little bit more about CFIH and how it operates in a little bit, because it is kind of important in terms of what we're presenting today. And we'll talk a little bit more about the aims of today in a few slides. But I guess today's workshop is all about a multidisciplinary approach to CBTE in outpatient private practice. And so we're really drawing upon our experience at CFIH. And really kind of referencing the CBTE model in particular, which, as we know, is one of the leading evidence-based treatments for eating disorders, and just looking at how a dietitian and a psychologist and GP can all work collaboratively together. And so we're not saying what we're doing is completely perfect. We're still really refining our processes and protocols. But I think this is a really timely presentation, just because, particularly with the new eating disorder management plan items, and particularly in outpatient services, we really need to think about how we're working together as a team and providing best care for our clients. So I look forward to working with you all for the next couple of hours. I just want to acknowledge the First Nations people as the traditional owners of the land on which we are presenting today. And we recognise the country north and south of the Brisbane River as the home of the Turrbal and Yagara people. And I pay deep respects to all elders past, present and emerging. Just a few acknowledgements. So collective wisdom of all of you today, your professional experience, your personal experiences, also our supervisors and educators, our director, Kira Buchanan, and also past and present CFIH team members in working together in what we kind of are doing at the moment here at CFIH.
Awesome. Thanks, Danica. So thank you for filling out the survey before today's workshop. It allowed us just to have a little bit more information about who was joining us and what their experience is, and particularly around eating disorders. So from our understanding today, we have psychologists, psychology students, and a couple of business owners as well. If there's anyone else in the group, other dietitians like myself, which I'm highly doubting, but please let us know if there is anyone else. And from that information, we gathered that approximately 65% of you work with eating disorders less than 30% of the time. So we're just conscious of that in terms of what we're presenting today. So if there is any questions that do pop up throughout this, please let us know. We'll do our best to make sure that we can answer those at the end too. And the other parts that we realised in terms of what you've all been working with in terms of eating disorders, the average was about 5 to 6 years. And we do see that there was a bit of a range in terms of how long you might have been working with eating disorders before. And again, we'll do our best to reference that throughout the workshop with what we're going through today. Interestingly, it came up in the information too that greater than 70% don't work within multidisciplinary teams typically when it comes to eating disorders. And I think it was about, I think it was about 25, almost 30% of those people, there was sort of split between maybe dietitians or GPs that they might work with if they are working in multidisciplinary teams. So of course that's, all of these parts here are quite relevant with what we're speaking about today. So I'd be really interested to hear from you all throughout, and particularly towards the end, if that shifts at all, if there's any barriers that come up to seeing involving, for example, a dietitian in care, which I have no doubt that there probably will be, and something we're going to talk about today. But yeah, just really interested to see if that shifts throughout this in terms of interest in working with multidisciplinary teams. In line with what Danica and Megan have chatted about, what we're really hoping to work through in today's workshop with you all is to support you in improving your understanding of how a multidisciplinary approach might work in private outpatient practice. And we're particularly today focusing on the role of a psychologist with a dietitian, as well as a medical professional such as a GP. And how this might particularly work when it comes to the model of CBTE, so cognitive behavioural therapy enhanced. And this is going to be, as we talked about, so the main part we're focusing on today. And we're hoping that we can share with you some of the what the model that we use in our clinic in practice, and discussing some of the, this has been evolving over years, and so definitely, we'd love to share with you some of the challenges that have come up for us and how we've been overcoming those. And again, in terms of the collective wisdom of this group, we'd love if there's more insights that you'd like to add to that too. So just really briefly, in line with that, we're going to break it up to 3 different sections. Firstly, just introducing around the research with eating disorders and multidisciplinary, and then focusing a little bit more on how that works in practice and with CBTE and the multidisciplinary team. And we, again, if you can bear with us, as Megan mentioned, there's been some last minute technology changes, but we're hoping to do some more group activities. But we're going to do our best to work with you as part of the group chat, and potentially, we can make that work, let's just say, as we go. But yeah, we'd really love to hear from you all about, as I said, your experiences and questions that pop up for you when we're doing those particular activities. And then lastly, as I mentioned, we're just going to finish with some of those challenges and make time for questions. So we really want to make sure that that's, if you can, as we said, pop them in the group chat, or have them there ready to go so that we can answer those then. All right, I'll pass on to Danica to jump into the first part of speaking about CFIH as a service.
Yeah, so we are a private service, and we are a team of psychologists, dietitians, and now a psychiatrist that we have on site. So I think we've got like 6 psychologists, we've got 2 dietitians and 1 psychiatrist. We're also onboarding a student. So in terms of referral streams, we get a lot of referrals through GPs. That's the predominant referrer, psychiatrists, pediatricians sometimes, and most of our referrals are on the Medicare stream. Probably, I'm not sure what percentage, but a significant portion, and then a smaller portion would be private referrals. So a lot coming in through the mental health care plan, chronic disease management plan, and then of course now the eating disorders management plan. In terms of communication between the in-house team, so we have an online booking system, and that's where all of our communication occurs if it is like client-based. So we'll send each other messages or like prompts. When we take case notes, the case notes stack up chronologically, so you can see exactly what was covered in the last session by dietitian or psychiatrist. And then they might have a note saying, DA, can you follow up on XYZ? And then I will do so. What else on the online system? Yeah, I guess we've also got like another system, which is more just for like admin sort of chat type things, non-clinical. So just making sure, obviously, it's all confidential. Weight charts is another thing that we share. So again, online system, we are updating the weight chart with each client so that we can all access it and see what's happening there. In terms of communication with external referrers, so of course, just via letter, phone call, email. I feel like I'm at the moment contacting about 2 GPs a week, particularly with the new EDMP. I guess like some of you might have already found this is just like really helping GPs to kind of understand the process there. Really importantly, so when we onboard a new employee, they have to, in the first 6 months, fulfill certain clinical competencies. So for example, get mandatory training in particular eating disorder treatments, demonstrate skills such as being able to carry out like a risk assessment or send a client along for medical monitoring, or have filmed like a family meal in FBT, or to formulate with a client in CBT. So really like core parts of treatments. And then of course they're getting supervised and making sure that all gets done and completed in the first 6 months. And I guess just a little mention there with dietitians. So often they will be involved in, and we'll go through this later, in the initial assessment phase. And so just making sure they're also trained to do like a suicide risk assessment. So I guess when clients are first calling into our service, they're already being socialized and introduced to the multidisciplinary approach. So for example, front desk might say something like, it sounds like CBTE would be an appropriate option for you, given what we've spoken about today. So typically we book you in with both a dietitian and psychologist, and then go ahead and book a number of appointments in. If they have any kind of like concerns about seeing psychologist or dietitian, I guess we just sort of work with that, and whoever they see first would sort of talk through that a little bit. The other thing too is, I guess, when the client is, if they're booked in with both of us, they're consenting that we both share information with each other, as well as of course like medical practitioners. So confidentiality wise, that's covered there. There's also non-negotiable medical monitoring. So when the client is signing the consent form, they're also consenting that they agree that they will adhere to medical monitoring, and we are constantly reinforcing that and upholding that. And we're also, again, assessing from the outside, is the client ready for treatment, but also are they suitable for outpatient treatment specifically? Do they need a higher level of care? And of course, in reality, it's a little bit grey. So we do have the Queensland Eating Disorder Service admission criteria. So generally, if they're meeting those criteria, we would be thinking about like hospital admission, but I guess them being so clogged up, their system being so massive wait lists as well as ours, it's about sort of juggling that and just making sure that the medical side of things is really well taken care of. So just talking you through a little bit about the research on multidisciplinary CBTE. So as most of you would probably know, is multidisciplinary approaches to the treatment of eating disorders are considered best practice. In terms of CBTE specifically, there's not a great deal of research that looks at multidisciplinary CBTE. So we know CBTE is generally an outpatient therapy, and it is single clinician led. And I guess there's like good reason for that in terms of like research, consistency, professional integrity, things like that. But I guess in reality, when we're working in this population, there is a high level of complexity. So, often finding significant gastrointestinal difficulties, struggling to put on weight, specific diets and all that sort of thing. And this is what we're seeing in outpatient treatment. So it really brings to question, and also with the EDMP, the 20 sessions, how can we involve the dietitian and how can we work together non-eclectically doing a CBT approach? So you might have heard of some of Riccardo Grave and colleagues' research over in Italy. There's a multi-step CBT ebook. And basically there's evidence of in like inpatient and day program settings of the dietitian and psychologist working in tandem doing CBTE. And I kind of feel like that's what we're doing here to some degree at CFIH. And it just is kind of like a diluted day program in a way. So there's no specific research that we're aware of that examines the outcomes of a dietitian and psychologist facilitating CBTE in tandem in outpatient private practice. But definitely on our minds to get some research going. It's just a little tricky time-wise in the private land, but yeah, something we've got our eyes on. Yeah.
If only, hey, we had a lot of time, that would definitely, we would have, we'd be collecting a lot more data and really starting that now, but definitely the planning is there, that's for sure. With CBTE itself, we're not going to go through it in a lot of detail today. We are, of course, going to go through a bit more about the psychology and dietitian roles. But we wanted to just start, given that a lot of you haven't maybe don't necessarily work with eating disorders as your predominant caseload, we wanted to just start briefly with a bit of an overview of CBTE. So these are the 4 stages of CBTE. So starting with stage 1, which is called starting well, and that's really where we focus a little bit more on where the client is at starting, so their behaviours. So we work on things like self-monitoring, regular eating, some education around the eating disorder, engaging them in treatment. We'll go through, as I said, that in a little bit more detail, but that's stage 1, and that's over 8 sessions, which is recommended to be twice a week. So for the first 4 weeks, that would be stage 1. Then when we enter stage 2, so that's predominantly 1 or 2 sessions, and we're really just reviewing where have things got to at the moment with the eating disorder, what improvements have been made, and then really planning for stage 3. And that might be talking about some barriers that have come up to treatment already, as well as where might we start with some of the modules in stage 3. And as I said, that's just 1 or 2 sessions. So stage 3 would be talking about 3 specific modules. So the first one being body image, the second one being dietary restraint, and the third one being events, moods, and eating. Again, we're going to go through these in a little bit more detail. Another then component, the last component of stage 3 before going into stage 4, is really working on the setbacks and mindset. So the eating disorder mindset and understanding it in more detail, and supporting the client to have some skills in navigating their eating disorder mindset. Before finally finishing with stage 4, which again is a few sessions on the main 20 session protocol. And that is about relapse prevention planning as a predominant main component of that. And as I just mentioned there, so there's 2 different parts which we'll go through in a bit more detail with CBTE. The standard is a 20 session protocol, and then there is another protocol which is typically the underweight, more complex, which is 40 sessions. So that's, as I said, just a little bit of an overview with what CBTE looks like. Before now diving into how we have split this up at CFIH, where we're focusing on, well, how does the psychologist and dietitian work together under this model? And the way that we've done that is by, so first of all, starting with stage 1. So we alternate between the psychologist and the dietitian. So as I mentioned, that is 8 sessions over 4 weeks. So we typically, as best as we can, try and alternate between dietitian and psychologist. So that really starts off treatment that they are seeing both of us, engaging them with each clinician, as well as, you know, that we're all getting to know their eating disorder together. And we'll go through, as I said, a bit more detail in a moment of the tasks that we'll do throughout stage 1, but we really make sure that they were all on the same page starting off. Stage 2 is predominantly done by our psychologists here. As I said, that's basically reviewing where treatment is at and where treatment will go moving forward. In stage 3, this is where we find, I think, like particularly really beneficial of having both the psychologist and the dietitian. Like the first part, we're sort of working on the same task from different angles, whereas this part in stage 3, this is where I think I really feel that we can bring both of our backgrounds and expertise to these, as much as I hate that word, to this area. So for example, I really value, working with psychologists, of course, for lots of reasons, but in this part here with stage 3, events, moods and eating, so that they can really go through that in a lot of detail with the client. And as well, body image, and again, what else might be coming up with their eating disorder and body image. And then where, as a dietitian, we'll predominantly focus our time and energy with the client in stage 3 of dietary restraint. And that module focuses on predominantly really like diet rules. So understanding what rules have come up for them that their eating disorder has created or found in our world that we live in. There's lots of places, unfortunately, that can be very confusing about nutrition. So that's a key part that, as I said, here at CFIH, that's where our dietitians really focus on supporting the client with understanding those rules and having some experiences within the CBT format of some evidence for or against what the eating disorder says is going to happen. And then finally, so the setbacks and mindsets will be predominantly psychologist run. And then we end treatment in the same way that we started, with alternating between the psychologist and the dietitian, and focusing there on the relapse prevention, as I said, predominantly, and maybe, where to from here in terms of, again, both of our backgrounds. So as I said, this is like, we're kind of diving into, this is the overview of CBT and how we do it in a multidisciplinary way. And now we might speak through a little bit more of how we work together throughout those different stages. And what we're going to do is start with the dietitian specific role. And we thought we'd start there because, obviously, being a group of psychologists, this might be something that, as I said, some of you may or may not have worked with dietitians in practice. But I think particularly with the new EDMP Medicare rebates available, I guess what I'm really conscious of as a dietitian is that there will be a lot of dietitians that will be seeing clients. So I guess firstly, hoping that they do work within eating disorders, but then secondly, understanding a little bit more about how they might work with the client. And then if it is CBTE that you are doing, I think just really us understanding, well, are we doubling up? Are we missing some things? So as I said, I'll jump into the dietitian role a little bit more now. So typically in eating disorders, this is where we might work through with the client. I guess predominantly a lot of people, or traditionally maybe we've had that reputation that it's basically, here's a meal plan. And unfortunately, some clients may have had that experience in the past. Here's a meal plan, go and follow it, see you later. But thankfully, that is not predominantly what we do, or I absolutely would not be in this space. So, what we do outside of that is really supporting the client and understanding some of the impacts potentially around their eating disorder behaviours. So where our psychologists find within our role as dietitians that we might explore a little bit more in detail would be around things like vomiting or laxative use or irregular eating, and really actually supporting the client to understand some of the implications that could have, as well as debunking some of the myths that come up, for example, with things like laxatives and the impact on weight. With nutrition education, again, as I said, I don't love the word expert, but that word is there because that's predominantly how a client will talk about how they appreciate being able to. It's so scary, as we all know, for them with the eating disorder to be able to take that leap of faith and eat regularly or challenge some of their food rules. So they said, in a world that is so confusing about nutrition, they really appreciate having that nutrition expertise to be able to support them in taking that leap. We do a lot of debunking food myths, and again, as you probably have already touched on a couple of times, things are so confusing around food, nutrition, weight. There's so many things that people have heard or read, and their eating disorder has often really grabbed onto that. And so to really support them in debunking that, and of course in the CBT way, having some experience or evidence for themselves to actually test that out. Does that actually happen? What's the reality, when I do trial that? So it's a big part of what we do. But in terms of support towards intuitive eating, I've put that there because it is something that does come up, and it's something, and as I put there, of course, that will significantly depend on the client's stage of eating disorder. And what we do with that is it's more about how we speak about food and bodies, and it's a longer spectrum. So of course, when it comes to the eating disorder compared to intuitive eating, that might be where we're working towards. But of course, we're not going to start by utilizing, unfortunately, appetite cues and things like that. But rather, I do have a number of clients, for example, with binge eating disorder that I work with, and they've once they sort of go through initially with stage 1 of CBTE, they're starting to bring back some of their intuitive signals around appetite and cues. And this has been a really key part that they've been interested in learning more about after CBTE. So again, it's just sort of the language that comes up around food. Support in navigating diet culture and fat phobia. I think that's again a key point. We support a lot of clients in, particularly around, I would say, the body image module, but just in general when it comes to food and weight, which is a key, which is 2 key parts that we talk about in CBTE. It will be quite difficult if we're not speaking about that at all to sort of then send them out into a society that is very diet and weight loss obsessed and fat phobic. We have a lot of clients in bigger bodies that we're really validating their struggles that they've been through and how much they've been told that they need to lose weight. So it's a key part of what we do talk about too. And then just finally, in terms of meal support and modelling normal eating, again, that's a key part of dietary restraint module that we'll go through. And a lot of people have said that they found that really beneficial just to actually have a dietitian there, just eating and modelling normal eating with them as part of meal support. And bringing that together with some of the, as I said, some of the core eating disorder topics that we might go through, I guess there's some of the things, as I mentioned, that I wanted you to keep in mind if you are working with a dietitian outside of CBTE, is just giving some thought to what might they be covering. Because as you can see throughout this slide here, they, for example, they're addressing the restrict binge cycle, talking about regular and adequate eating, working towards more flexible eating styles, challenging some dietary rules, and potentially body image. They might be working on this. So we're going to talk a little bit more about the importance of that communication process. But I guess what I'm just floating out there as a bit of an idea is if you are working with dietitians, for example, is just checking in, what are they doing and what am I doing? Because it might be, I have worked with a lot of clients too that feel like they're getting very confusing messages if both people are practicing or talking about the same topics, but maybe in different ways. But also, I guess it lends for dietitians too to sort of see, actually a lot of our skills are within CBTE. So do we need to focus our practice within that? And as a multidisciplinary team, I guess, again, just coming up with that plan together. So I'll hand over to Danica to jump in with a little bit more about the eating disorder management plan too.
Yeah, so I guess this is just a refresher. It's not going to be a session on the EDMP and the ins and the outs and the details, because there's still things that I'm still figuring out. But I guess we know dietitian can have up to 20 sessions, a client have up to 20 sessions with a dietitian subsidized by Medicare, and then up to 40 sessions with the psychologist under the new EDMP. And so in this instance, GP will unlock the initial 20, and then at session 2, they have to get reviewed again for the psychologist by the GP. And then the psychiatrist and GP both need to conduct another assessment at session 20 to unlock the remaining 20 with the psychologist. And of course, they have to review again with the GP at session 30. Some considerations in how this kind of lines up with the CBTE model. So there are 2 CBTE protocols. So one is the 20 session protocol, and that's generally for your non-underweight profile. And so kind of, if you're doing kind of tandem CBTE, it might be 10 with the psychologist, 10 with the accredited practicing dietitian, but I guess it will depend on your service structure and as to how that will look. In terms of the 40 session protocol, so this is for underweight, 40 sessions with the psychologist potentially, and spending a long time, we find, in stage 1, waiting for that weight restoration to take place, and then 20 sessions with the dietitian. So we're kind of going to move on to, and our timing's going very well. Like, how does this look in practice? So we're going to kind of go through the stages of CBTE and draw reference to a few kind of case examples, got a few activities. So the assessment phase of CBTE, I guess stepping back a little bit, across treatment, we see that the psychologist is the primary clinician. And I guess that's just because CBTE was like written for a mental health practitioner to conduct. Unless, however, the accredited practicing dietitian is more senior. So for example, if say the dietitian was experienced with eating disorders, practicing CBTE and working with an external psychologist who potentially didn't have as much experience with ED or wasn't trained in CBTE, or at our practice in particular, dietitian working with one of our new kind of psychologists, it kind of looks a little bit more like the dietitian as primary clinician. In terms of the assessment phase, we have a standardized initial assessment that we all complete. We all upload to the online system that I was talking about before. We all fill out our case notes using the same format. And then there are 2 assessment sessions as part of CBTE. So the first session is always more diagnostic, just collecting a lot of information about background, history, but really paying attention to, I guess, physical, medical risk. And the second session is more like collecting any more information, but really setting up CBTE. So it's like setting up like self-monitoring, completing the formulation, talking about in-session weighing. And so because psychologist is primary clinician, it's really important that that second session is completed by the psychologist, because that's going to set up treatment essentially. So I guess, also both the psychologist and dietitian we're both socializing to CBTE and like CFIH as a service, again, going through the regular medical monitoring, that being a non-negotiable part of treatment. We're assessing readiness for change, commitment to treatment. So we're having lots of conversations about, can you attend weekly? Are there going to be any big breaks in treatment, just like CBTE? And then if there are any challenges seeing either psychologist or dietitian, we're just having those conversations very openly and seeing if we can sort of troubleshoot, making sure they're getting in to see both of us. I think I just want to raise like a little bit of a case example. Kate and I had a client last year, and I did an assessment, and this client had lost a significant amount of weight and was like training, exercising a lot, and there was binging, purging behaviors. She was quite restrictive, and she was in a bigger body. And so I just sort of thought, oh, this does not feel good at all. So I set up medical monitoring. She got along to her GP, I think it was that day. And I phoned the GP before the appointment. And after the consultation, it was revealed postural tachycardia, abnormal ECG, ketones in blood in her urine. So yeah, I guess making sure that we're really carrying out that physical, obviously not in the detail that a medical professional would, but really checking in on those symptoms in that first assessment there. So another point here is we have a treatment folder for CBTE. We have also one for FBT, but the client will give that to the client at the end of the second assessment session. And that's got all their documents in it, all this information. They can read through the CBTE protocol, bring it back and forth from sessions, add in their formulation, have all their self-monitoring in there. So it's just a really good go-to. Yeah, so that's the assessment sort of aspect. I'm going to hand over to Kate to talk a little bit more specifically about the medical management, just because it is really, really important. And if you are new in the field of eating disorders, it's something that is absolutely crucial.
Yeah. So the medical management or medical monitoring is a non-negotiable that we support our clients in engaging with a GP if they've not already done that prior to engaging with our service. And I mean, predominantly, of course, as many of you would be thinking about with our clients, is of course their safety is number one. And sometimes they have maybe seen a GP a little while ago, or but maybe they haven't actually been assessed in terms of some of the symptoms that, as Danica mentioned, they might bring up. And some of the eating disorder behaviors that can come up can, of course, bring out red flags for us of, really making sure that they are engaged with a medical practitioner. And that they're doing that ongoingly to make sure that they're appropriate to stay in outpatient therapy. So ideally that would commence, of course, before we do see them. However, I would say, the majority of the time that hasn't happened, unless it's been referred by a medical practitioner. And so that's, as I said, something we're going to talk about initially, and then regularly. So I'd say it's something that it's running on our agenda. To make sure that we're checking in with, have you seen them recently? And sometimes we do have to, really support them in session to re-engage with them. And sometimes we do, as Danica mentioned, we do play a lot of phone tag, but trying to collaborate with the GP just to check in regarding their risk, and if we do actually need to go to a higher level of care with this high-risk group. We do make sure that when the client, whenever they do cease with our service, that we hand that back over to the GP, or the medical practitioner, to let them know that, they won't be seeing us anymore. However, we do want to make sure that they're still getting that ongoing care. Something I think, as Danica sort of mentioned there before, with engaging with the medical practitioner, sometimes we do need to either advocate or discuss any contraindications to therapy. So an example that comes to mind is another client that Danica and I shared as well, who had been diagnosed with an eating disorder, but was actually being recommended by their medical practitioner to lose weight, and had been prescribed Duromine as well. So it's, just checking in with their medications and their, what else is happening, I guess, as part of their treatment team. And that was definitely, a conversation that was required to have early on to discuss, given that they have an eating disorder diagnosis, let's actually discuss the appropriateness of this medication. And finally, case conferencing is something that we do quite regularly with, for example, psychiatrists, GPs, or in my case, psychologists that may be off-site. And just making sure that, you know, we're all on the same page, and that checking in with things like medical management. You know, sounds like there've been some barriers that have been coming up. Can we problem solve that together? And ideally always doing that with the client first and foremost. But sometimes this is more touching base about the treatment plan, just making sure that we're all on the same track. And again, if I'm doing CBT with someone externally, that's definitely going to be on my mind, to make sure that we've got that regular communication. So we've gone through the assessment. We've gone through the overview of CBT. We've now jumped into the assessment and just medical monitoring. So we thought we might just pause there and actually think about, you know, a client that is coming in for this initial assessment phase. So we have a bit of an activity here. I'm just thinking, because we won't be able to see the group chat. So Megan, we might have to ask if you can maybe call out some of the answers, or potentially people could unmute and call out their answers too. So I'll go through the case study and then we'll go through some of the questions, if that's okay. As I said, thank you for bearing with us. We did have that this was going to be a breakout, that you're going to go into breakout rooms, but unfortunately we found out at the last minute that wasn't possible. So, the case study that we're working with today is a 22-year-old female. She attended an initial appointment with you and reports the following symptoms. So amenorrhea, so loss of period, weight loss following restrictive dieting, recently attending a 12-week gym challenge, fear of weight gain. She has a lot of food rules about what's good and bad and what foods that she feels she should and shouldn't eat, a lot of preoccupation with weight, shape and its control. There's found to have excessive exercise. There's also some occasional purging and binging, so once a fortnight. Her current weight is 70 kilos and she reports that her previous weight was around 85 kilos. So just giving some thought to this young lady and where we might start with her, as we said, in terms of that initial assessment. So I might throw it out there. As I said, we could throw it on the group chat. Megan will just have to share that with us, as unfortunately we can't see the chat. In terms of what you feel the diagnosis might be for this client, what your initial thoughts might be for the diagnosis.
I have the poll for that question, Kate and Danica. Would you like me to run
Yay.
that?
Oh, my apologies.
Awesome.
You
No,
do.
that's all right.
We can see that part.
Good.
Excellent. So if Megan will pop up the poll then. There we go.
Oh, cool. This is so cool.
So hopefully there you should be able to see that.
We do have 2 responses in the chat as well, suggesting atypical anorexia.
Yep. Thank you. So we'll just give that a couple minutes while you're popping in your responses. Thank you. Okay. Danica, did you want to speak to that one? No.
I'm just looking at the numbers. So at this stage, we've got most folks saying atypical anorexia nervosa. So we've got 11 people saying that. We've got 3 people saying anorexia nervosa. We've got 2 people saying bulimia nervosa. And so far no one for ARFID or binge eating disorder.
We do also have a few responses in the chat. So Gail, you shouldn't need to submit. I think you can just click your answer and it'll come straight through. But we do also have some comments saying that that it's not ready for a diagnosis. You need more information, and another comment saying she needs a full medical workup and she'd be priority for medical assessment.
Yeah, great.
Thank you. And my apologies, we did change it at the last minute, so we've got the poll. So thank you, Megan.
Cheers. Yeah. And so I think some of you have already sort of answered the second question there, but Yeah, in terms of diagnostics, certainly, of course, we don't want to sort of throw out diagnoses straight away, but just kind of going off the information there. Does someone want to kind of jump out and some brave person want to jump out and say why they made the atypical anorexia nervosa call? If not, that's okay.
You can unmute
if
you wanted to do that.
Oh yeah, that's.
Hi, it's Janet.
Hello, Janet.
Hello. Thank you so far. I think this is something that I think is so important, and I know you're about to talk about it, but the importance of not being distracted by occasional other eating disorder behaviours like binge or purge behaviours, that it's about looking at the dominant symptoms and what's actually the primary aspect of the eating disorder. And I think sometimes when there's a binge or a purge infrequently, people can assume bulimia nervosa, but actually it's about looking at what are the dominant symptoms and the dominant psychopathology of the disorder as well. Yeah,
absolutely. Yeah, and so which one did you select?
That atypical anorexia nervosa.
Atypical anorexia nervosa, yeah. And that's what Kate and I have come up with, and we did create the case purposely to demonstrate this, because this is a case that we are finding more and more in outpatient private practice, and it flies under the radar all the time. And that's why we want to bring it to people's attention, because it's so dangerous. And these are the clients that are often getting told, well done, you're losing weight, that's great. And we really need to get better at picking this up as professionals. So yeah, it doesn't, and I guess there's also argument to say, why are we calling it atypical anorexia when actually it's the same as anorexia? You're just at a different body size, but actually you've lost significant amounts of weight, you're highly restrictive, you're exercising excessively. It's really, really dangerous. Does anyone else have any more commentary on that particular question?
I'll just unmute myself. We do just have an answer in the chat just saying that she would fit that diagnosis because she has all the cognitive requirements but does not have the low weight. So as like you were just saying.
Yeah,
that was myself, and I was just similar to what Janet was saying. Like, if you look at DSM criteria for anorexia, this young female would meet all of it but the low body weight.
Yeah.
So hence going with atypical for that reason.
Yeah. Good one. Yeah.
Yeah, and like Danica said, very common, and this, particularly something like a 12-week challenge or something like that. And, sometimes they might present to a dietitian as part of continuing with that weight loss. So as Danica mentioned, really important for us to be on the lookout for those, definitely.
Yeah.
So moving on to what might be some important first steps in engaging and supporting this client in treatment. I don't believe that we have a poll for this question. So I wonder if you wanted to give some thoughts to what might be some important first steps. And if you'd like to pop those ones in the chat group, that would be great. And again, Megan, if you can assist us in letting us know what some of those answers might be. Again, if anyone's, feels is brave enough or wants to unmute, feel free to jump in with your thoughts on the first steps too. Or some potential first steps.
We've got some answers on the chat. So Eliza suggested the GP, and Lucy has suggested get a full history and detail around the behaviour, and she needs a medical workup. Ensure a dietitian and a GP are involved. And we do have some other comments coming in that are also saying medical review, input of a dietitian, recognition that it's an eating disorder. And Janet's come up with a few steps: medical assessment, prioritise nutritional adequacy, and education about binge as reactive.
Yeah, great.
And Wendy's also mentioned family involvement if she's still living at home.
Yep, great.
And a couple of comments there too about engagement and the importance of engagement. So I think the consensus is, yeah, like medical workup, dietitian involvement, engagement.
Yeah, we've got the chat now.
Okay, great. Sorry, yeah, we can see some bits of the chat.
Awesome.
So yeah, thank you. Yeah, so like you said, medical monitoring sounds like one of the key parts, particularly early on. And a few people have mentioned engagement. Yeah, so assessing their readiness to change, assessing how and supporting them with engaging in treatment in general. So whether that is particularly with a medical practitioner, as well as, of course, yourself. I think they're the main parts that we can see around there. I can see some parts around, like you've talked about, potentially the restrict binge cycle, some education around regular eating, checking in with like motivation. Yeah, I think it really is part of the that assessment phase. I guess like our first thoughts would be checking in with medical, particularly straight away, to making sure that they're engaged with the medical practitioner. So I love that that's, definitely, as you've said, priority for medical assessment there straight away.
Just jumped in.
There we go. So moving on to the third question. So what are the most, what are the potential appropriate treatment options? So we've put some examples there again in the poll. So if you wanted to jump onto that and pop your answer into the poll there, we'll be able to see that.
I think we got. Oh, that's a funny thing, isn't it?
Or closed.
Oh.
I think
I've just relaunched it, sorry, just to see if we can get more answers on the second one.
Great.
Thanks for bearing with us with technology, everyone.
Oh. I could do that.
Yep.
There we go.
Great.
Let's make sure I change it to the next slide.
Beautiful.
Yep, so far CBTE is the majority. Mantra, a few of you have said. Yep.
Yeah, so I mean, this will depend greatly, of course, on your background, on your training, the areas that you feel most comfortable with. But in terms of eating disorder treatment, we just sort of wanted to throw out there some of the evidence-based treatment models, and just giving some thought to, what your thoughts might be in terms of treatment for this client. Predominantly what we would do at CFIH is typically start with CBTE in terms of evidence, and particularly for this presentation for this client. And given that it's sort of an earlier presentation, they're a younger individual, that might be where we would predominantly start. And again, start there and chat about CBTE with the client and see if that's something that they feel like they're ready to engage in as well. Awesome.
Good stuff. And then the last question is kind of what, who should we involve? What other professionals? Who's part of the treating team? So if you want to pop some answers in the chat, that would be great. Or if you want to just, jump in, speak out.
And Megan, if you're able to get rid of that poll, if that's okay. I don't think I can. I popped it out. It just keeps popping back in, so hopefully that should be okay.
Yes, I noticed that. I'm just trying to get it to go away.
Great. No, that's all right. I couldn't get it out. So that's all right. Thank you.
Is it?
What have we got on in the chat? 2 new messages. Oh, just a few. Great. Yep, psych dietitian, GP, psychiatrist. Yep. We've got some people saying family, partner. Absolutely. Yeah. Yep. Other medical specialists if necessary. Great.
Yeah, so it sounds like you're all on the same page that we were thinking as well. You know, as we've talked about, you know, definitely a medical practitioner very early on, and then you know, so obviously for yourselves, maybe that might be a dietitian early on. But I would say, you know, first and foremost, the medical practitioner is always who we're looking at involving, and then, as you've said, you know, carer supports, whether that's family, partner, etc. And I guess, you know, depending on your style and where you're at with this client, it might be, you know, bit by bit, just in terms of not wanting to overwhelm them with, you know, dietitians, psychologists, psychiatrists, GP, exercise physiologist. You know, we often find that it can be really helpful to just work through that stage by stage, which I'm sure that you would all do as well. I don't think there's anything. Yeah, so there might, as you mentioned, might be some other, like a peer worker, and we might think of those sort of things, you know, down the line as we make sure they're medically safe and that maybe we've got them engaged in treatment and starting off. Absolutely. Thank you.
Were there any other questions in that realm that people had? No? Okay. So moving along a little bit, we thought it'd be helpful to talk a bit about our roles, similarities and differences, because there is crossover, but as sort of Kate has mentioned, there is going to be sort of, our own backgrounds and profession speciality that we're bringing to the table. In terms of the similarities across CBTE with the psychologist and dietitian, we're both trained and supervised in the delivery of CBTE. We're both reviewing the formulation, which is a really crucial part of CBTE treatment, and helping to educate the client on the eating disorder cycle. In our sessions, we're both like using the self-monitoring forms to review the week. We're both encouraging regular eating. We're also both practicing from a health at every size lens. So for those of you who haven't heard of health at every size, I'm not going to go into it because that's a whole other topic. But essentially, it's like a weight neutral health behavior approach to health. If you'd like to know any more about that, please feel free to email Kate or myself. And we're also both contributing to relapse prevention planning. In terms of the differences, so I sort of spoke about the psychologist being primary clinician. So we are initiating the formulation, we're initiating the self-monitoring, we're doing the in-session weighing, and I'll make a little asterisk here because I'm going to come back to that in a little bit. But we're also driving the stage 2 review, and we're also leading the relapse prevention planning. In terms of the dietitian, so the dietitian is going to be providing more in-depth education regarding the physiological impacts of the eating disorder, debunking food myths, you know, talking about gastrointestinal difficulties, and yeah, really, I guess, honing in more on those physiological symptoms. Psychologist, we're going to be doing the majority of stage 3 modules. We're also going to be doing the broad form of CBTE. So there's some other modules aside from the core protocol. So perfectionism, interpersonal difficulties, low self-esteem. And then the dietitian is going to be completing the dietary restraint module in stage 3, as Kate has mentioned. And just something that I guess we've kind of noticed in practice with regard to the self-monitoring, because we are both like reviewing it. As a psychologist, I sort of feel that I'm focusing a little bit more on like distress tolerance, moods type stuff in the self-monitoring that shows up. Whereas Kate might be more attentive to the food rules showing up and kind of paying attention to where the client is at in with their eating. And so we use the RAVES, regular, adequate, varied, eating socially, and spontaneous eating model that Shane Jeffrey has developed.
And I guess, specifically within CBT, so for example, in stage 1, of course, we're predominantly working on regular eating as part of that. And so, like you said, in the self-monitoring, you know, we might be problem solving with them around regular eating. Like you said, you know, yours might be more around the distress tolerance. and supporting them with that, whereas ours might be sometimes like maybe the practical kind of forms around, you know, convenience or how to support them with, you know, having snacks. So like you said, of stage 1, it's really the same task, but we're coming at that from two different angles.
Yeah. And the other thing too, Kate and I have a current client who comes in and sees us on the same day. And so I found that if she sees Kate first, in our session, we'll spend a little bit less time on the self-monitoring. And so I just, know that nutrition stuff's been covered, so I can really hone in on the distress, anxiety stuff. Yeah, that's one of the wonderful benefits of the multidisciplinary approach. You've got more time. Okay, so stage 1, these are sort of the tasks through stage 1, and I've just sort of done little tick boxes to kind of show who's doing what. So we talked about the assessment session 1 being diagnostic, and at CFIH we basically see that psychologist, dietitian, psychiatrist, eventually hopefully is doing the diagnostic assessment, and that's where, as I mentioned, all of that risk stuff, it really needs to be covered. And then assessment session 2, where we're going to be getting further diagnostics, looking at the impact of the eating disorder, setting up the CBTE, socializing CBTE, formulating. That's going to be the psychologist who's the primary clinician. And then therefore session 1, which is where you start the in-session weighing, you review the self-monitoring, you review the formulation, you start to educate about weight change, is again the psychologist. And then from sessions 2 to 7 in the short protocol, essentially you can see that both of us are going to be completing these different tasks. And as Kate just mentioned before, we're coming at it from slightly different angles. So that's where there is a bit of double up, but I guess this is the whole thing about, what I was talking about in terms of the research, non-eclectic practice, us being all trained in CBTE, us talking to each other, us communicating with each other, so that, we're not spending 15 minutes going through the self-monitoring with the psychologist, then 15 minutes going through the self-monitoring with the dietitian, and really, trying to avoid that double up. But of course it is inevitable, and that's something also we're working on.
Yeah, and I guess definitely like in terms of CBTE as it's designed, of course it's with stage 1, 2 sessions within the week, and that, really supporting them with checking back in. So it is going to be the same task, like if it was 1 clinician or 2, we're always going to be checking back in, for example, with the self-monitoring, but it's just, as we said, doing that through those 2 different lenses, which clients have really reported they really appreciate having those 2 different lenses to support them with their eating.
And I've put a little asterisk, so going back to what I was saying before, for the underweight protocol, you spend far longer in stage 1, and that means that the dietitian is going to be weighing the client, because also when you're seeing them ideally twice a week, and in the underweight protocol you do weigh them twice a week. That is something that plays out with that longer protocol.
And the main difference, like you said, between 20 sessions and 40 session protocol. But that's a really nice snapshot of stage 1, the tasks that we do throughout stage 1, and how we differentiate those between dietitian, psychologist.
So we've got a bit of a session structure example based off of CBTE that we put in practice. So the way I might structure my session is, client comes in, I weigh the client, we go through the self-monitoring, we set an agenda, we review the formulation, and then there'd be the big chunk remaining of session where there might be some education about eating disorder cycle. We might be focusing on some coping skills. We might be covering items, obviously we're covering items from the self-monitoring that shows up. And then with the 40 session protocol, I'd be completing the activities in the underweight chapter. And of course, this is like the majority of sessions. So I'm also just going to draw back to a client that Kate and I are currently seeing. And so I've been just going through the activities in the underweight chapter with this particular person, and she will see Kate, and their session will be largely focused on how can we get the food intake in. So and your session structure, KG?
So again, just a bit of an example. So we might briefly review where they're at with their self-monitoring for the week, and then add any particular parts to the agenda and come up with that collaboratively. And then we'll dive into the self-monitoring a little bit more specifically. So review, for example, some if there's been some occasions throughout the week that have been particularly challenging for them. We'll review how they're going with regular eating predominantly. And then there might be, we might do some work together around understanding the eating disorder a little bit more, and particularly the eating disorder behaviours that are showing up. So it might be vomiting or laxatives, or difficulties with eating regularly, excessive exercise. So, we might spend a little bit more as part of their treatment that week. We might focus a little bit more on education and understanding what's happening with eating disorder behaviour. And then, of course, as part of CBT, setting that homework collaboratively together, problem solving, and putting into plan a bit of a place about how they might be working on reducing some of those eating disorder behaviours this week. That's a bit of an example of how we might do that. So now that we've gone through stage 1, we're really aware that, as we said, that many of you don't maybe necessarily work with a dietitian at the moment. So we thought we'd pause here and ask a little bit more about getting some thoughts of maybe the common barriers to your clients seeing a dietitian, or for you working collaboratively with a dietitian. And again, we're going to break out into rooms. So if you can maybe add some of your ideas into the chat group, we'd just love to maybe have a bit of a discussion together as a group, because the last thing, of course, that we want to do is, be talking about a dietitian and psychologist working together when you may be sitting there going, but I've had a lot of difficulties with that, or, but my clients say this. Of course, we can talk, more if there's other parts that come up in the questions at the end, but yeah, we wanted to make some time now to actually address some of these and talk it through together. And I'm also really hopeful that, given your experiences, that some of you might have had different solutions to these different barriers that have come up for yourselves too.
So I think we've got down here, this one, client isn't ready to change, barriers, cost, time, anxiety, access to dietitian in an area if remote.
Absolutely.
Yeah.
Private practice psychologist, it's more challenging to work in a multidisciplinary way. We hear you. We've both worked outside as, I guess, sole practitioners in private practice too. So I guess that's why we want to talk a little bit about our service, of understanding that it is a little bit different and interdisciplinary, but we do have experience in both, sole practitioners and then being a little bit more collaborative now in person. So it looks like, very few dietitians trained in eating disorders, probably a difficulty everywhere, Laura has said. I would agree. And I've definitely, as part of this presentation, added in there some a couple of places for you to find eating disorder dietitians, because I think that is a real challenge too. And of course, like myself, when you are referring to somebody else, you've built trust with this client, rapport, you want to make sure that you're referring them to somebody that's going to be, supportive and trained in this area. So time and cost, I think, is another one that keeps coming up. Lack of access, previous negative experiences with a dietitian. Yep, definitely. I can talk through that a bit more too.
Say they don't usually work with clients with it.
And so maybe talking to that one a little bit more, previous negative experience with dietitian. I guess I think I hear that a lot. As a dietitian, I think that's something that they might say coming along too. I'll see that they might cancel initially, or Danica might see that, and then we might have that conversation that, previously they've had a negative experience or a not helpful experience. And that's definitely one that I see for people as well, whether it's, a psychologist. I have a lot of clients at the moment, with previous negative experiences with a GP. And so I guess it's just speaking through, with them, validating, unfortunately, of course, it's just like, anyone else that they might see, is that unfortunately sometimes we don't get the best match, absolutely. But potentially, like you said, maybe having a bit more understanding about who we're actually looking for this time, is this a dietitian trained in eating disorders? What's their experience? Let's maybe spend a little bit of time there together. And ideally, this is something the client will undertake too, to make sure that it will increase the chances, let's say, that this person that you're referring to is going to be trained in eating disorders. And I guess as something that we sometimes talk about as well is, let's do our best of finding the most appropriate person. And I would do that, if it's a psychologist externally too. And can we give that a go? What would be the worst case scenario? Kind of speaking through it with them too, if they're willing and open to being able to try that. Of course, you've got to have some confidence, in who you're referring to as well. But we often find then that a lot of people, really, oh, okay, this was different. It is actually, for example, a dietitian or a psychologist trained in eating disorders, a very different experience to their past.
What else have we got? So yeah, cost is a big one. What else have we got? Readiness for change, and then we've got schedules as well. A dietitian being undervalued. Yeah.
Some clients undervalue the contribution of a dietitian.
Yeah.
And it's different to Googling a meal plan. Yeah, thank you, Janet. I think that's, again, something that comes up quite a lot. And one we thought, do we want to role play with that? Or one exactly that we thought, very common. I already know everything about food. I would say that's probably the most common one that I hear, and probably psychologists, or some kind of variant of that. I know everything about food. I don't need to see a dietitian.
Yeah, we could role play that one.
Yeah, did you want it?
Yeah.
Okay. So if it's helpful, we thought we can role play, I guess, a bit of a common example. So we'll use that one there of, so I'll be the client.
You'll be the client.
Yep, you can be the psychologist. And so Danica's just opened up maybe the conversation about me engaging with a dietitian.
Yep.
And so as the client, so I would say, like, I really don't want to see a dietitian. To be honest, like, I know everything about food. They're not going to be helpful at all. I really, I don't see the point in that, would be my.
Yeah, Kate, I really hear you. And like, I've heard a little bit about some of the experiences you've had before, and they haven't been so helpful. So I can totally understand where you're coming from there. Yeah, I guess, and also I know you do a lot of like research around food, and you really know your stuff. And so it's certainly not that I don't trust that you know your stuff. I think it's more coming back to, how we did the diagram of the eating disorder cycle. Do you remember doing that a few sessions ago?
Yeah.
Yeah. That's good that you remember. And in the middle we had down, like, you had food rules as a really big part of the eating disorder cycle. And
Yeah.
And we're sort of talking about how that whole cycle is kind of like a way of thinking and interacting with the world, and a way of viewing things from a particular mindset. And we talked about it being like the eating disorder mindset.
Yeah.
That's good that you remember that. And I guess why I think it might be helpful to see a dietitian is, I want you to have a really good objective way of looking at food rather than from that eating disorder mindset. So it's sort of like if you were to Google, for example, carbs or fats, do you think, if you were in eating disorder mindset, do you think that you'd be looking at all the articles that say how great fats are for our, neurotransmitter functioning or our memory or whatever? Do you think you'd be looking at all the articles that tell
I don't
you
see
how
those
much?
articles. Yeah.
Oh.
I think I definitely see all the bad things about fat, and that carbs are bad, and that I shouldn't be. Yeah, I just really shouldn't eat. Really shouldn't be going near any of that stuff.
Mm-hmm. And that to me sounds a lot like eating disorder mindset. Like, what do you think?
So maybe if we break there, I guess, like, that's a bit of a common example that obviously, Danica, thank you. Like, this sounds like something you've had a lot of experience with, unfortunately. That, I guess is commonly that the client, of course, like, they might have been calorie counting. I would say even, like, I see many clients who are macro counting, micronutrient counting even. So I guess they have a lot of information about food, but of course, if that was in a helpful way, then they wouldn't be here they wouldn't be getting support around their eating. So I guess that's a bit of a common example that does come up, where absolutely validating that they may have had difficult experiences in the past, or that potentially they do have a lot of nutrition information. I'll often say that to clients too. You know, hey, you could probably spell out the calorie or macro or micronutrients far better than I could. But I guess what I would come down to, and not in this blunt way, but, you know, has that been helpful, basically? And so, yeah, hopefully we can support them in being able to have a healthier relationship with food. But of course, that's a very complex thing in the world that we live in today. So add in an eating disorder. I would say without an eating disorder, that's complex enough.
Does anyone have any kind of burning questions regarding this kind of reflection space that you really would like to be addressed?
Or any other solutions to any other problems that have come up? Or I guess even particular questions, you know, something that you get really stuck with. And it's okay if not now, like we can chat to it more at the end. Just thought I'd throw it out there.
Yes, I've just had an issue recently. I see a client in private practice on the eating disorder management pathway, and I suggested to the client, and she was open to it, about seeing a dietitian. However, she then went to speak to the GP for the GP to do that, and the GP then said, I don't really think that's needed.
Oh,
so it's kind of like, when, I guess, it's how, given that the GP is kind of in control of sessions and who sees who and who does what, how is the best way to then get a GP on board?
Yeah, that's super tricky. In that instance, I think like what we've found is helping the client to, I guess, tune into how did that feel for you, and then using that as a bit of a leverage to get them to advocate for themselves, because obviously we don't want to kind of go around like cutting all of our medical ties, but like, and I guess this conversation comes up a lot when clients are kind of getting told to lose weight when they're seeing us for an eating disorder, and it's kind of like, well, how do you feel? Like, what do you think of that? If, you know, if your best friend had gone in for that consult, what would you be telling them, helping to get them to get that perspective? And then a little bit of and, you know, how can you advocate for yourself? Like, what do you want to do about that? How do you want to take charge? Like, helping to empower them. And if they want to keep seeing that GP, that's completely, we'll support that. And it's just kind of recognizing this is where we might come up against a few tricky points, but again, it comes down to the client making that choice themselves.
Yeah, I love how you started there, like in terms of supporting and empowering the client in advocating for their treatment. And that might be, if that's, I guess, like depending on the client, depending on the situation, it might be, I have had some psychologists that will touch base with the GP or put that in their letter that I would recommend that the client, I guess, just bringing about supporting the client in their efforts to engage with a dietitian. Yeah, I guess they're the other parts, like, of how we could step in terms of advocacy, but always starting with the client and empowering them first. Yeah, but that's really tricky, and I think that's really difficult if you've had that conversation with the client and then somebody else in the treatment team has said, oh no, that's not necessary. I imagine that would have been really tough, and tough for the client too.
Yeah, definitely.
Yeah, thank you for sharing that. So please, if there's any other parts, please add them into the chat box and we'll get to those at the end. So we'll jump through. We've just got the last
little bit now. So stages 2 to 4 of CBTE, we're not going to spend too long on them because that's where it is quite clear where the roles are differentiated. So stage 2, as we've mentioned, that's psychologist led, so anywhere between 1 to 2 sessions required for that formal review. Stage 3, psychologist body image module, events and moods module, setbacks and mindsets modules, and then dietitian doing dietary restraint. Stage 4 is both of us, psychologists leading the relapse prevention, but both of us contributing to that planning. And then, of course, as I mentioned before, the broad form of CBTE, so perfectionism modules, low self-esteem, interpersonal, completed by a psychologist. So what I've done on the next slide is just a little bit of a diagram that took me bloody forever because trying to line up the lines is just a bit of a nightmare, but that's all right. And this is a a client case example that Kate and I are seeing. It's the one we've actually talked about a little bit already today. And it's just to give you an idea of like what a 40 session protocol looks like. So I guess presenting issue is anorexia nervosa restricting type. So as you can see, where I've ticked the boxes is basically who she saw on that particular session. So for the first initial assessment, I saw her, and then Kate saw her second. And I know that I said earlier that ideally the psychologist sees them for the second session as primary clinician. However, we weren't going to be formulating with this particular lady until I think it was session 1 or 3 as per CBTE book with underweight protocol, just because cognitively she just wasn't able to do that. This particular person was, very severely malnourished and medically compromised when she came in and had a quick short hospital stay at the beginning. So there are a couple of times where, because in reality it doesn't always work as beautifully as psych dietitian, and I got stuck overseas due to COVID. So she does see Kate several times in a row, as you can see early on. But I guess, stage 1 for this particular lady has been very nutrition focused, just because we really need to get her safe and well. So as you can see, what we're up to now is stage 3. And we've had altogether 27 sessions between Kate and myself just in stage 1. And we're moving on now to stage 3, and we anticipate that we potentially are going to need another sort of 20 to 25 psych sessions to complete body image, moods and events. We will definitely need to do perfectionism module and ending well. And Kate will probably need 10 to 15 more sessions with this particular client to continue the weight restoration and complete the restriction, restraint and ending well modules. So just a note on this client too, she's in a circumstance where she can come and see Kate and I on the same day. So I kind of call it like a little diluted day program, and she sees, GP another day of the week, an exercise physio now that's just been brought into the treatment team, psychiatrist. So she's really got the wraparound care, which I think is also contributing to why she's really doing quite well, and she's on a really good trajectory. It is trickier, of course, and Kate will sort of talk through some of the tricky bits with like cost and that sort of thing for other clients who can't come in and see the both of us on the same day. So I've just put a note there. Also GP, seeing weekly, psychiatrist, seeing fortnightly at this stage.
Yeah, and I guess as you mentioned, that does work for that client, but for the majority of clients, we do like to and really, as much as we can, try and prioritize that they will see the one of us earlier in the week and then one of us later in the week, so that their support is, of course, staggered across the week, as you mentioned. This has just been something that particular client has set up, and her she unfortunately has severe and enduring anorexia nervosa, and is in her late 40s, early 50s from memory. So she's had her eating disorder for a long time. So of course, we've been really working with this client to see, what's going to be most useful for her. And that's been something that she's really benefited from, having a bit more support, across that day. So we've been talking a lot about how does this work, how we do it in practice, and some common client scenarios that might pop up. So now we thought we would talk a little bit more about some of the challenges that does inevitably come up. And I would say probably multidisciplinary in general, but of course, we're going to be speaking to this a little bit more specifically with CBTE. So some of the common challenges, and I think maybe, you might have already pulled some of them up when we talked about the dietitian, but difficulty engaging with another clinician. And that does happen, of course, for clients that I will see, in difficulty engaging with a psychologist or the GP or the psychiatrist as well. So we see this as an opportunity to, really discuss with them, talk about previous experiences potentially, problem solve, talk about what they might worry about in seeing a dietitian or a psychologist, Sometimes there's some like improving interpersonal skills does come into it too. But yeah, that is a challenge that comes up, I would say, with multidisciplinary in general, as you've mentioned. In terms of CBT, a little bit, well, I guess a little bit more specifically, but maybe eating disorder treatment in general too, potential for double up or missed tasks. So if we talk about this CBT specific protocol, as you know, it's very manualized. It's, you know, the tasks are very specific. So there, like, a key part is, you know, clear setup and communication process. I would say is that, you know, the predominant part. We're lucky enough, as I said, and we do understand that that's not how the majority of people work with the interdisciplinary approach, that we're both in the same location. In saying that, I do work with a lot of psychologists externally. So again, that clear setup and communication process is key. And trying to keep it as simple as possible. So I guess like a really common example, you know, I might do the predominant part of the dietary, I'll do the dietary restraint module, but it's stage 1, you know, and maybe stage 4 a little bit, but typically by then, you know, it's pretty clear, but it's really stage 1, setting that part up. Okay, are they alternating between us both? You know, how do we have that clear setup process and communication with, for example, weight charts, which is the next part. And as the dietitian too, you know, if the psychologist is weighing them, it's really important typically that, you know, we both, of course, but with what we're going to talk about regarding food, that we do check in, you know, what has actually happened with their weight, particularly if this is an underweight client that's needing to restore weight. Other parts there, I guess, really around, again, specifically to CBTE, supervision, adherence to the model, so support with that, I would say we've found really helped to actually make sure that, you know, tasks aren't being missed. Okay, what is, you know, particularly when you're getting familiar with the CBT protocol in itself, what am I doing in this session, you know, so that, again, that's really clear between the practitioners, that they know what they are doing in each session. In terms of disengagement with one or both clinicians, so both would of course be dropping out of treatment or temporary disengagement. Again, I would say that this pops up a lot within eating disorders. I guess something that we do here at CFIH is, because, you know, we've been working in this area for quite a while, and we do see some of the common barriers that do come up to completing treatment. We preempt a lot of these with the client. So I guess like a example would be in the first really session to 2, we're going to be talking about things like cost, you know, who is funding treatment, would there be any concerns with that, and really actually spelling it out. What's that going to look like, seeing a psychologist and a dietitian each week, potentially as well as a GP or a psychiatrist. Of course, as unfortunately as we know, eating disorders and eating disorder treatment is very expensive. I guess more in the private space as opposed to publicly. So, you know, we just wanted to preempt some of those things, and potentially it might be a public service that's, you know, is more appropriate for them to be engaging in. So we'd be addressing that early on before we actually jump into CBTE. Collaboratively problem solving, of course, and again, an opportunity to improve interpersonal skills if they have, for example, and again, it's quite common if they might disengage with one of our clinicians. I think I would say that that's a bit of, I find particularly a bit of a pro in terms of us being in the same space, or just both having that together, is that, you know, I might notice that they've cancelled the last few sessions with the psychologist, but they're only coming to mine as example, and Danica has definitely found, you know, the opposite. And so then, you know, that's an opportunity to address that with the client and have some transparent, open conversations. And it might be that, I don't know, they might not have, you know, built rapport with one of us, or, you know, there could be obviously a multitude of reasons that could pop up there. But I guess I do find that, you know, improving interpersonal skills, particularly when these clients, and I have had a lot of clients that, you know, have just disengaged with clinicians very commonly throughout their eating disorder treatment without the opportunity to actually talk through, you know, what was coming up, what were the barriers. So yeah, I do find that can be a really therapeutic conversation, and can really support them in actually engaging in treatment moving forward. And then just finally, in terms of challenges, as we've talked about, and as, you know, many of you have probably mentioned too, working in different locations, of course, you know, not being able to see each other and have that close case conferencing or see each other's diaries, etc. Of course, that's going to bring in a lot of challenges. And where I've found it to be most helpful, I guess I would say, like, firstly, and I think maybe some of you have brought up too, is being confident with who I'm referring to. So establishing a referrer network. So we, over the years, have built up, whether it's GPs, psychologists, dietitians, psychiatrists, social workers, etc., outside of, so external to CFIH, that we commonly work with, or we know work within eating disorders, so that we can be confident with who we're referring to, and for our clients. And then again, regular communication, however that's set up. And I guess, you know, as Danica spoke about, the way we would do that initially would be through letters. And then if there's something a little bit more urgent or needing to be addressed, we would make a phone call or an email, just in terms of normal eating disorder collaboration.
And then there's this, someone put in the chat, the issue of splitting.
Yeah.
I thought that's
that's a great point. I think something that, I think splitting is like a whole conversation in itself, and definitely something that we have had, I guess, many, you know, case conferences around and supporting our clients with.
And I guess they're also in the new, like, EDMP items. I think psychiatrists can bill for the teleconferencing, and so I guess that's helpful in terms of just that regular kind of case conferencing and really using those items for what they are. Because I'm just sort of thinking of a particular case where there is definitely splitting happening, and just that team cohesion is just so important, and that communication.
That's what I'm saying. Team cohesion definitely, and I guess, like, coming back to the client of how can they sort of address that as best, and that, you know, we're all keeping, I guess, in terms of splitting, like, is it actually, like, are we kind of allowing that to happen as well? And having conversations, you know, with the team of, and with the client, like, how to actually break those down so that there's not actually the possibility for that to happen, as much as possible, of course. But the case conferencing is a good one. And it's definitely something we talked about with, when we were advocating for the EDMP. Many of us, particularly I think in private practice, you know, really advocated for the case conferencing item number. At this point, it's not included. Look, fingers crossed for down the track. It's something that we spend a lot of our time doing as it is, but of course, we all know, many of us in private practice, you know the challenges that come with that. So just finishing up, we've just got a last few slides here before we jump into some questions, but some ingredients for what we have found, I guess, on the other side of, you know, what has been supportive for multidisciplinary CBT from our experience. I've touched on the first one, you know, really that clear setup and communication process, specifying roles. So as I said, whether that's in-house or externally, I'm always going to spend that time with the clinician to just really talk about, you know, who are our clear roles. And then it might be, if one of us is a little bit more experienced, look, this is how we typically do it. How does that work for you? You know, should we trial that and touch base again in X amount of time, or over letters? How are we going to set up this communication process? I think particularly with the weight charts as an example. But all activities, you know, and we will sometimes do weight charts as part of this if it's externally, is making sure that they are shared. So typically, as Danica mentioned, we actually have a hard copy, a treatment folder. So then they put everything in that. And we find that so helpful, because then, you know, no matter who they're seeing, it's all in the one spot. Again, if it's internally, we will upload a lot of that so we can see it. But if it's externally, which, you know, I imagine a lot of you are going to be working with, that treatment folder, we will socialize the client initially when we do start with treatment. This is really important, and we find that this is something, you know, we're going to have to talk about, particularly initially. Hey, I see that you've forgot your treatment folder today, you know, and that might be something that we might problem solve, but how important it is they keep their self-monitoring in there. It might be their weight chart, it might be, you know, different activities that we've done, you know, that I might, like Danica might have done, you know, assessing readiness to change a little bit more, and pros and cons of their eating disorder or whatever that might be. And we might be utilizing some of that information when it comes to, you know, engaging in regular eating. So that can be really helpful as part of that. Both clinicians really closely reviewing stage 1 tasks. So we talked about, you know, clear case noting, regular reviews. just really making sure that we're sticking to that as part of stage 1 before going into stage 3, which is a little bit more specific in terms of the modules. And then finally, just some opportunity to review complex cases regularly. It's really common for us to touch base with treatment teams as in any eating disorder practice, but particularly with CBTE, to make sure, hey, is this person actually progressing? Where are we at? What are some barriers that come up? And of course, we're going to do that with the client in session wherever possible, and first and foremost too.
And just sort of jumping in there too, currently, like this year, we've introduced on like a Tuesday after lunch, we do case reviews or a clinical masterclass. So basically, we're going through the chapters of CBTE as a team, or we're going through cases and like all collaborating on how we can kind of, it's basically like group supervision essentially.
And we find that's really helpful, like again with different case reviews, so different clients that we might share that we bring to the team, so then we can all learn, okay, what are some of the barriers that are coming up, and how can we all support how can we support these clinicians in problem solving and overcoming some of that. And I think we all really find that valuable, because of course we're learning from lots of different cases and very common situations that arise. So just to finish with a couple of slides there, as I said before we jump into the questions, I just wanted to let you know, in terms of eating disorder practitioners, I've particularly focused, of course, on dietitians here. Someone mentioned, and I just realised I forgot to add it on there, sorry, but ANZ. So ANZ AED is definitely another place to jump on for eating disorder practitioners. And I believe that, just like with Dietitians Australia, so we used to be DAA, Dietitians Association of Australia, very recently changed. Huge change, I know. Dietitians Australia is who we are now. Inside Out, Butterfly Foundations, they all have practitioner databases on there that, for example, you could go in and put dietitian to your state specific typically, so whether it's New South Wales, etc. And then you'll be able to have a bit of a list of clinicians that work within eating disorders. So, for example, on the dietitian's website, you'd also add in there the eating disorder specific to find those dietitians working in that area. So bringing together what we've talked about today, as Danica started with, the current evidence really recommends multidisciplinary approach for eating disorders. However, unfortunately, at this stage, there are no manualized multidisciplinary therapies. So in terms of CBT in itself, because it has such a strong eating behavior component, and as I've mentioned, it is a lot of the parts that commonly a dietitian will talk about with regards to food, we find that it does lend itself to multidisciplinary approach, and we have found it really helpful here at CFIH as being able to support the client with that multidisciplinary approach. And I mean, another part of the way that we talk about this too is that at the moment, as I said, unfortunately, nothing does exist in terms of evidence-based approach. So we've started with evidence-based treatments and the multidisciplinary approach. Let's start here and let's utilize this, and particularly with the EDMP coming out now, that the dietitian, the client may, if they are eligible for that, have access to 20 dietitian sessions and 40 psychology sessions. Let's utilize that in the form of CBTE. So that's why we focused on that in our practice, and we're really hoping that that's something that you might consider in your practice, or if it is how I am working with a dietitian, are we doubling up on some of these things if I am doing something like CBTE, and how can we make this communication process and supporting the client in these areas more streamlined. And then finally, I think a lot of us are, would love to do a little bit more research in this area, but really focusing on a multidisciplinary approach to eating disorders, whether that starts with CBTE as part of that, whether that is something else. I know from my understanding, there's a few people working in this area and wanting something to come out. Because I think, again, coming back to the EDMP, and I think as a couple of people have talked about, that at the moment that doesn't exist. So we're all doing the best that we can at the moment, utilizing the evidence that we do have. But it would be great, of course, if we can, which I can see coming in the near future, to be more about multidisciplinary approach to eating disorders. So that brings us to the end of today. So we do have a bit of time now for questions. And while maybe Megan is hopefully grabbing those for us too, and we can have a little bit of a look on the chat, we just wanted you to give some thought to what might your take-home message be from today, and is there any way or any change that you would make to your current practice? And if you'd like to share any of that with us on the chat, we'd love to hear that too. And finally, thank you all so much for joining us and for bearing with us with the technology that happened at the beginning. Thank you very much. We appreciate it.
So I can just go through some of the questions that came through the presentation, and then everybody feel free to add any that are coming through now, and we can address those as we go. So Claire had a question during the presentation about the Dutch behaviour questionnaire, and then she also just asked a little bit later, a bit more generally, about how much you're using questionnaires and measures at stage 1 or later.
Yeah, great question. So we initially introduced the EDQ before they came to see us, and that's something that we're working on getting that, as I said, in terms of outcome monitoring and collecting evidence around it. It's something that we're looking at just finalizing our particular protocol around. But yeah, typically when a client will start with us, that's definitely what we'd recommend, of doing something like the EDQ, or it might be again at stage 2 that commonly comes up to.
No, that definitely. What's the other one in the book called? The clinical
CIA.
The CIA.
She's also asked if you recommend the recovery record app, and she's just had a couple of comments about that it can be quite time consuming and hard to keep the dietitian and myself on the same page when we don't know one another, but working via email and telephone can help to keep things in sync, and she's just wondering if you have any comments on that app.
I use Recovery Record for a select few of my clients and kind of try and get most of them to self-monitor and hard copy just because of the ease of, particularly with multidisciplinary sharing. But I guess it's with the Recovery Record, it is a little bit, when you're trying to sort of flick back, and it can be a little bit nuisancey in that regard. But I think some clients who are having trouble engaging with it, with the hard copy, that's where I go, all right, we'll go with electronic. And then in terms of multidisciplinary, just thinking of a client of ours, she gets out her phone and goes through it in session. And I guess it would just be then making sure if she's gone through it with Kate, then I'm not going through it very at length.
Yeah. And I guess like with CBT, from my understanding too, the ideal is really using the paper form, in terms of like them writing it out. We do find that when it's sort of on one page and we can sometimes put them out, that actually is a little bit more therapeutic in them being able to see the links of like the restrict bin cycle, different days and different patterns around their eating. But as Danica mentioned, of course, I would say, a lot of clients do go to the Recovery Record app because of just its convenience, being able to pull out their phone, wherever they are, and being able to put it in. So that is something that a lot of clients will use. I guess in terms of the time consuming part of the question, I think previously, like when I was working with Recovery Record, I think I used to, try to jump on or want to support the client during the week. But personally, like in private practice, I just find if I did that for one, I'd have to do that for all of them. So that would definitely be something that I would do in session with them, as opposed to jumping on. Because I guess that opens up a lot of difficulties and complexities around what you could see and supporting the client there too. And I guess just finally the part of, with the dietitian, I guess again it comes back to the roles and who's doing what. So with whether it's self-monitoring or the Recovery Record, how are we utilizing this as a multidisciplinary team? So then that might give a bit more clarity of how you might utilize that.
And we also have a question about the RAVES model of eating. Shane Jeffries, Claire's commented that she finds this helpful as a dietitian, and I think you did say on one of your slides that you do use it.
Yeah, definitely. Yeah,
it's inbuilt in the CBTE, but as in, we go through regular and adequate eating, varied and challenging dietary rules, and moving towards flexibility. But I couldn't agree more, and that's really what Shane's, from my understanding, really what Shane was hoping with that it's quite a clear, specific and sort of simple form that really, starting with that base of regular eating, then let's not be looking at variety or anything like that until we've established this base. So the raves, for anyone who hasn't heard of it, can jump on Google and find it too. And it is really helpful as that base for anyone.
And Anna had a question about whether in-house, you probably covered this as we went along, but do dietitians and psychologists meet to discuss treatment plan, the EDP, or joint sessions, or what's your kind of preferred way of working together on the treatment plan?
Yeah, in terms of meetings, so this is where we'd kind of use the online system to say, hey, do you have some time on this day? I've booked it out to discuss X client. And there are some occasions where it just so purposely, and sometimes it just so happens that the client is seeing one after the other, like within 2 hours. Then I have the last 10 minutes come in to the dietitian and said, hey, this is what we covered today. Here's kind of where we're at, and then hand it over in that regard. So definitely joint sessions, where possible. I don't think I've had a full, complete 1 hour joint session, because that's just a bit tricky billing wise. That'd be amazing. It's just in billing wise we can't, but we do sometimes do a little crossover at the end.
Yeah, so we do case reviews regularly, as we mentioned, and then, as Danica said, we typically will meet up quite regularly. Okay, who are our shared clients? Let's just touch base with a couple of those that might be a bit more complex, or we might preempt some of the issues that might be arising, and just making sure that we're both on top of those. Yeah,
and just one last one from while we were doing the presentation. Claire just asked about how much you're doing telehealth, and if you have any thoughts around this.
So just on the telehealth, I think the CBTE website has an article that they released around COVID, when it sort of really came out, about how can we do CBTE on telehealth, and that's really helpful. And basically they're saying there's some research indicating that it's it can be just as effective. I guess it's kind of paying particular attention to, there's clients who are very underweight and medically risky. So that would be kind of a bit of a limitation with the telehealth, and something to consider. That, I personally don't think I would see a client who is underweight, medically risky via telehealth. But at the moment, I'm not sure, I'm only seeing maybe a couple of clients telehealth, and I don't think I'm doing CBTE CBT with them. What about you, KG?
Yeah, I do have a couple, but I should say a few, but ideally we're coming back to now in person. We're in Queensland. I know that's a little bit different to Victoria particularly. That's where we're at in Queensland at the moment. So the majority of ours are now in person, but there are some definitely. And I guess the main things is in terms of the collaborative weighing as part of, particularly in stage 1, and medical monitoring. I think they're the key parts that I've really, spoken about with those clients, of how we're going to set that up, and just coming up with a problem solving with that. And as Danica mentioned, particularly looking at if there is risk of medical or weight that we do to be on top of, coming up with a plan, which was very challenging. I'm sure many of you found throughout COVID. But thankfully a lot of our GPs are coming back to being in person too. But I do really feel for a lot of people around the world, Victoria as well, that's still very challenging.
And just with the in-session weighing component, it's just being a little bit creative, thinking outside the box. How are we going to do this? Can we get a support person? Are you going to weigh there with me at the beginning? Are you going to have someone there and they're going to take the scales away? Could you do it at the pharmacy? Or just do it with the GP, and then the GP relays the information. So making sure that you're still doing that aspect of treatment if you're doing CBTE.
Yeah, it's a good point. We've been very creative around who and how, and which is great to see those creative skills from the clients as well. I'd say hopefully therapeutic too.
Wendy also has a question in the chat. She's wondering if you have, and a few other people have asked this as well, if you have any CBT ED manuals that you recommend for private practice use. She said there's a lot out there, but would you, do you know of any that really stand above the rest?
This one is the go-to. This is the big one, the best one, because this is the guy who wrote the program, and it's very laid out, it's very straightforward. So yeah, I would be going this one first and foremost above anything else. It's so cognitive behavior therapy, eating disorders, Christopher Fairburn. Yeah.
Christopher Fairburn.
Yeah. Thank you, Janet, for adding on there about online training with Credo as well.
Yeah.
There's lots of different trainings that do pop up. That one is one that, you know, does go through quite specifically and give different examples and actual role plays.
And I think just for those folk who are in Queensland, I think the second half of this year, QEDS, Queensland Eating Disorder Service, I think they are running CBTE training. So yeah, those in Queensland, get on phone QEDS, ask them about it.
And do it from time to time as well.
Yeah.
I'm not sure in terms of COVID if they're going to online as well. But yeah. Great. Well, I'm conscious of time. Is there any last question, Megan, or?
It's just a couple more. Sorry, I'm just making sure I don't miss anyone.
Okay.
We just have another. So Janet's just asked, any thoughts about scope of practice for those who don't use multidisciplinary treatment? Is this a problem with traditional single practitioner CBTE?
So Janet, sorry, do you mind if I ask a bit more? What do you mean by that? Like in terms of, do you mind speaking to that? Sorry, a little bit more?
Yeah, sorry, it's a last minute question on the last minute, sorry. But I guess it's just, it's a kind of rhetorical question about, I think multidisciplinary treatment is the only way to go, because otherwise psychologists step outside their scope of practice, I think, in talking too much about nutrition, which often ends up then being informed by their own eating patterns. So I think I love everything that you said today, and, you know, thank you for your sharing, because I think that's so important, and it's a question that, is a problem with CBTE. That is my dog trying to get in. A CBTE done by one practitioner is, I think there's way too much stepping outside scope of practice, actually. So I love what you've presented. Thanks.
Yeah, that's
I think that's a really great point. And I think, you know, similarly in terms of the dietitian, of course, like with diagnosis, etc. So I think that's where it is such a great, it does lend itself really well to that multidisciplinary team. And as you've touched on, I wish there was a lot more training and support around people's eating and weight and body image concerns themselves working in this eating disorder space. Something I'm very passionate about, maybe, you know, in future, getting a little bit more involved in. But yeah, that commonly, I have had many clients that have said that that's been their experience, whether it's with a GP or a psychiatrist, have been recommended particular weight loss diets because that's what has worked for them, or that's what they find helpful with other clients. So yeah, it does come up quite a fair bit. So thank you, Janet, for speaking to that too. Appreciate it.
Like the population of eating disorders, most of them have gastrointestinal difficulties. Most of them have complex medical issues as a knock-on effect. And I'm just going, I've got no idea what to do with this. So yeah.
Thank you.
Well,
great.
It's probably all, we are at 3 o'clock, so we're at the end of our allotted time. I will send through the slides to everyone again, because I know there's a few people mentioned that they didn't receive them, and we can also send through the name and the author of the book that Danica recommended. And thank you both so much, Kate and Danica. There's a lot of lovely feedback in the chat, but it was just a great presentation. We're very lucky to have had you both present. And thank you so much for your patience with our technological difficulties in the beginning. And thank you to everyone else for making it through those. And if any PUBIG members or anyone who's come along today have any suggestions for future presentations, feel free to just send us an email or put them in the chat now if you're still here. But that concludes, I suppose, the formal part of today. So thank you both so much. It was a great presentation.
Thank you, Megan, for problem solving and persisting. We really appreciate it. And yeah, thank you all so much. We really appreciate your feedback, and we're going to read through the group chat now a little bit more. But thank you all so much for coming today and making time. We hope.
Thank you so much. You were amazing, both amazing. Thank you so much.
Thank you. Really appreciate that
Cheers.
feedback.